So we are inviting Dr. Parvez, the young surgeon from Calcutta, and he will be speaking on, where is it gone? Toric IOL, the basic step.
Yes.
Moazzam Parvez from RIO, Calcutta. Please start the timer.
Where can I see the timer?
Sorry?
Where can I see the timer?
For the timer, 7 minutes is.
Okay, all right.
I'll let you know. At
Okay.
6 minutes, I'll let you know.
Okay. Good afternoon, everyone. I'm here to share my first few cases of Toric IOL. So I would like to start my presentation by quoting Dr. Abhay sir, that as advances in technology and techniques continue to erode the boundaries between the refractive and cataract surgeries, emmetropia has gone from an exceptional result to an expected outcome. The basics, a lens whose cylindrical surface is curved in both the horizontal and the vertical meridians is called a toric lens. The principal meridian of minimum curvature is called the base curve. Each meridian of curvature forms a separate line focus. The distance between these lines is called the interval of Sturm, and the spherical equivalent is calculated by adding the spherical power and half of the cylindrical power. Before choosing my cases for toric, I would like to avoid patients with ocular pathology, small pupil, and progressive retinal problems. I would like to do biometry for both the eyes and A-scan immersion or optical biometry with a good graph, K-metry with axis, and the latest generation formula. For Barrick, we use the Barrett Toric calculator, which is available on the APA CRS website, where we enter the steep axis, axial length, and anterior chamber depth to get the readings, where we get the angle at which we will align the diamond markers. The mantra for doing the toric would be mark, remark, implant, and align. So for the pre-op marking, we would align the patient eye level with ours. That would be done by making the patient sit on the OT table and escalating it to bring it to our level, place a speculum, dip the bubble marker in trypan blue dye, and align the bubble in the middle compartment and mark the 0, 90, and 180 on the limbal area of the patient. This is the Mendes ring in the center, which is used for intraoperative marking. And on the left side, we have the axis marker. This is an intraoperative snippet of the Mendes ring placed on the limbus, and the corresponding markings are correlated. So here is a video, if it's visible. So the first thing we would do, we would dry tap the markings, the cardinal markings. Once done, we would start with the intraoperative marking, which would involve placing the Mendes ring on the limbal area. Over here, I use a Sinskey hook to do the final marking. In this case, as you can see, it's between 0 and 5 degrees. It is repeated on the other side as well. Once confident about the markings, we move ahead with a normal phacoemulsification surgery. From here, we take a clear corneal incision made at 1 o'clock. The rexis, a curvilinear central, well-centered 5 to 5.5 millimeter rexis is very important, which would facilitate the IOL to be placed properly inside the bag and avoid decentration in the long term. As well-centered as possible, the rexis. Moving ahead with further steps, a conventional trench and chop is done to do the nuclear management in this case, which would be followed by quad mode, and now cautious cortical cleaning is done quadrant by quadrant in by manual irrigation aspiration. where the irrigation is kept stable and the aspiration probe goes in the different quadrants and does cortical cleaning. The cortical cleaning should be done avoiding any kind of PCR which would further stop us from placing a toric IOL in this particular case. We also need to be very careful about avoiding intraoperative meiosis, which would hinder now the rotational stability. As you can see, the diamond markers are placed at the optic haptic junction. The lens is placed in the cartridge and further pushed down the nozzle, making sure that the haptic does not get caught somewhere and the movement is mobile and free. Now under OVD, the lens is being implanted in the bag, making sure that the leading haptic lands inside the bag so that the dialing becomes easier in the next steps. The unfolding system of this multifocal toric lens is quite slow, so we use a ball dialer Sinskey hook to dial the trailing haptic inside the bag, and the lens is tried to be placed as gently as possible and the optic is being centered. Once the optic is centered, the IOL is placed before 1 clock hour so that the IOL dialing is as easy as possible inside the bag. Once done, we will start eating up the OVD. Meticulous OVD aspiration is done again in a bimanual irrigation aspiration mode. We will go behind the lens, tap the lens and take out all the OVD as much as possible before going for the final final dialing of the lens.
Time.
We would viscoil cleaning behind the lens, gentle tapping and hydration would complete my case, where I would see the alignment. As you can see here, the diamond markers are visible, and post-op dilated IOL position is marked with the marking and the diamond markers.
Thank you, Parvez. Have you finished?
No, I'm not done. Stuck somewhere. Oh. I'm left with 3 slides.
Your time is up, so if you can
Okay.
summarize while it's getting ready.
Okay. All
So
right.
in the meantime, I'll ask Dr. Parag Mukherjee, you do a lot of SICS surgery, high volume. Is there any place of toric IOL in your surgical practice of SICS? What percentage of cases do you do toric IOL in SICS?
Not many. When I find a gross cylindrical disorder, then I use.
Dr. Shah, any input for the junior surgeon here? Parvez is working very hard in Calcutta. Any input?
Well, I think probably he may have shown also because of the shortage of time.
Yeah.
The last part which I would like to emphasize is that I often try to use helone-like substance while introducing the lens rather than methyl cellulose. The reason is it's easy to remove it, number one. Number two, I invariably block the main port and the second side port before I remove my irrigation tubing.
Mm-hmm.
Irrigation tubing is the last one to be removed, because moment you don't do that and you have
There is a
removed it,
rotation.
there is a slight collapse of the chamber, and that also can invariably lead to the little bit of a rotation of the toric lens.
Dr. Yasin sir, any input?
I think removing OVD from the back of the lens is something very important,
Yes, sir.
because otherwise there is possibility of rotation of the lens. And as you said, we must ensure that the chamber postoperatively does not become shallow and again fluctuate. That is important.
So I have one observation, Parvez. You are doing the IA through the main port bimanual. That actually make your chamber unstable, and you can easily catch the posterior capsule if it is a lax posterior capsule. If you are using bimanual, it's better to use two hand from the side port rather than going through the main port. That's one thing. Other thing which you can do, if you can do under irrigation in IOL placement, or you can place the haptic, the trailing haptic over the bag. It becomes very easy to remove the OVD from behind the lens, and better to use Hilon or similar as Sir has suggested, because it can be removed as a bolus rather than hypermelos, and then just tuck the trailing haptic inside the bag. It's very easy. If you can practice, it's very easy.
Okay, sir. Okay, thank you.
And suppose if the alignment is not proper, what will happen? How the toricity will be not possible?
For every 1 degree, 3.3% of cylindrical power loss will be there, and after 30 degree, the lens will lose its astigmatic correction.
Is there any probability of increasing the astigmatism if it is rotated more?
More than 30
alignment is-
degree, the
Sir,
lens will...
what is your
Yeah.
experience? Is there any chance
Yeah,
of...
I mean, as he said that if you go beyond 30 degree,
Yeah.
but I'll give you one incidence. A doctor friend of mine from another city one day rang me up, and he said that I implanted a toric lens. The previous pre-op astigmatism was about 2 diopter, and then at the end of it, when I realized, it went to 4 diopter. Everything was normal. My surgery was perfect. I had done a absolutely proper alignment of the lens and everything. How did I get 4 diopter? Was the lens wrong? Was it that the company has given me a long lens? So simple thing, I asked him, what axis did you consider? Was it on a topographic this thing, or was it on your keratometer? He took a keratometric value. Remember, keratometric value gives on a minus cylindrical component, and toric lenses are on the plus cylindrical component. So it is exactly opposite. That's how his astigmatism got doubled up.
So we should be very clear about alignment.
Yes,
very
you
clear.
need to know exactly what
If
is the...
there is any misalignment, there is a website called astigmatismfix.com. It's free. You can put the data in, and it will show how much to rotate. You have to take the patient back to the OT and rotate the IOL.
Thank you.
Okay, thank you.
If it is stable and if it's non-central, I think you should be able to deal.
No, in keratoconus, it should not be done. Even early is not
Not stable.
stable. It preferably should not be done.